Good morning, everyone. My name is Namrata Varma, and I am a pediatric otolaryngologist in Long Beach, California. I want to thank all of you for tuning in to this lecture, and I also want to take this opportunity to thank our college for allowing me to speak to you today on the topic of persistent obstructive sleep apnea, post-tonsillectomy and adenoidectomy in the pediatric population. I have no disclosures. There is so much to say on this topic, and given the time restraints of 30 minutes, I will be focusing on the following two broader objectives. We will discuss the evaluation and workup of a child with persistent sleep apnea, and discuss both non-invasive and invasive treatment options for residual sleep apnea post-adenotonsillectomy. Sleep disordered breathing occurs in approximately 20 to 40% of patients, and specifically obstructive sleep apnea is identified in 1 to 5%. Both anatomical and neurologic factors play a role in decreasing the caliber of the nasal and oropharyngeal airway. In children that are considered quote-unquote normal without other medical comorbidities, should be monitored for factors such as weight gain, which we know can occur after tonsillectomy and adenoidectomy, and persistent mouth breathing, which can affect maxillary and palate structure, which can further go on to cause snoring and residual sleep apnea. In syndromic children, several of these factors are present prior to T&A, such as craniofacial anomalies like retrognathia, mid-face hyperplasia, obesity, decreased muscle tone, and are still going to be present post-tonsillectomy and adenoidectomy, so continued follow-up is essential in these children. Many studies over the last 10 years have reported an outcome of tonsillectomy and adenoidectomy in obstructive sleep apnea. You can see here there's such a wide range of success, especially when the parameter is a apnea-hypopnea index less than 1. Bhatta Chatterjee and colleagues reported the lower number for cure, but they also had a high number of obese patients in their study, which could account for this. These studies remind us to go back and not lose our obese pediatric patients to follow-up. So what do you do when you have a patient who comes back post-op tonsillectomy and adenoidectomy and has symptoms concerning for obstructive sleep apnea? Are they still snoring or mouth breathing? Are they having witnessed apnea events? Are they still having trouble in school? Are there any behavior concerns? Go back to the beginning, do a good history, because we also want to separate other sleep hygiene issues versus obstructive sleep apnea symptoms. Sleep apnea questionnaire can be very helpful with this. With your office exam, we want to focus on other areas of obstruction. If there are a lot of nasal symptoms and an anterior rhinoscopy doesn't necessarily show a deviated nasal septum or a turbinate hypertrophy, there is also the consideration of regrowth of adenoids, especially if the child was less than 4 when they underwent their previous tonsillectomy and adenoidectomy. Other things such as having a high arch palate can cause nasal obstruction from that encroachment of the palate into the nasal cavity. If the nasal exam or nasal history sounds allergic, they possibly may need some allergy testing. In the older child, you may be able to proceed with doing a nasal endoscopy or a flexible laryngoscopy to look for other sites of obstruction and get a better idea of the anatomy. Obviously, no child likes to be scoped, but if can give you at least a quick assessment of the adenoids in the office, or you can always get an x-ray neck, possibly in an older child, especially with a lot of nasal symptoms. A CT sinus is very reasonable. At any rate, a repeat sleep study should be obtained. In the patients who have had recent tonsillectomy and adenoidectomy, but you're still clinically suspicious because maybe they're obese or they have craniofacial structural issues that are concerning, or they had severe obstructive sleep apnea with an AHI greater than 10. Preoperatively, these children should definitely undergo a post-op sleep study at 3 months. So what are the decisions around treating these patients? Invasive techniques, non-invasive techniques, what are the things that we have to consider? What are part of the discussions before deciding on a treatment option? How severe is the sleep apnea? If the sleep apnea is mild and there has been a good quality of life improvement after the tonsillectomy and adenoidectomy with the reversal of symptoms, watchful waiting can be appropriate with good counseling with the parents, good follow-up, counseling the parents on what to look for. We'll get into that, a little bit more of that in a moment. You also want to look at the medical comorbidities of the patient. Maybe their tonsillectomy and adenodectomy warranted anesthesia and surgery, but perhaps putting them to sleep multiple times is not ideal due to their diagnosis of sickle cell or having a history of a coagulopathy. And these reasons may guide you to a more non-invasive approach. Of course, there's always parental concerns to discuss, especially because some of the bigger surgeries to open the airway can call for a bit more manipulation and hospital stay. So these are all important factors to consider. So what is the rule for watchful waiting? It could very well be considered a viable approach. A study in 2014 noted that in none to mild symptoms post-op, watchful follow-up actually showed an improvement in symptoms around 8 months post-op. More studies have to be done in children as they are growing and their anatomy is changing. But again, quality of life is important when making decisions about further treatment. If a parent sees that their child has had significant symptom improvement, they are sleeping better, not having the daytime sleepiness or behavioral issues, doing better in school, they may not want to do anything, even if the sleep study shows some residual sleep apnea. So here again, counseling on symptoms, what to watch out for, and follow-up is very important. Weight loss. This is a tough one. It's very important that we participate in this conversation with our patients and their parents, given that obesity epidemic that is spreading through our pediatric population. 18% of children meet the criteria for obesity in the United States. And as you saw in earlier slides, obesity decreases the percent of patients who have sleep apnea resolution after tonsillectomy and adenodectomy. So exercise and diet is very important. Some of these children will require nutrition consultation, even psychologist evaluations. A lot of our obese patients are referred to endocrinologists to look for other metabolic issues that could be concurrent with their obstructive sleep apnea. So on the point of obesity and weight loss, although studies are still early and not so many centers are doing them, bariatric surgery has shown improvement in obstructive sleep apnea when implemented. Medication options can include your intranasal corticosteroids and possibly leukotriene modifiers like montelukast. A lot of studies have showed that the combined use of these meds reduce the severity of sleep disordered breathing because of the receptors present in the lymphoid tissue in the airway. Their benefits are still likely short-term. Once you stop them, there is a risk of return of symptoms. Also in the past year, early last year, the FDA placed a black box warning on the use of montelukast given the mental health side effects, and is not recommended to use in mild symptoms. If the decision to use montelukast is there, then again, counseling and what to watch out for with parents and patients is very important. On the topic of medication, as a side note, little things to look out for include, are children on any sedating medications, even such as oral or intranasal antihistamines? This can definitely worsen their sleepiness and obstructive sleep apnea, as well as potentially interfere with daytime behavior. CPAP can absolutely be a treatment option for children. Of course, it is less recommended for many obvious reasons. Rate of adherence is a big one. Literature shows anywhere between 5 to 55% rate of adherence for wearing CPAP masks. There is a higher compliance rate in females and children with developmental delays, but these things can also be affected by nasal symptoms, just like in adults. And so if a patient has a lot of nasal congestion or nasal obstruction, they will not want to wear the mask, and these things need to be addressed before CPAP mask use. DeFeo et al. Controlled for many patient and sleep apnea characteristics, and what they came out with was that parental, mainly maternal, education was the greatest predictor of CPAP adherence. Adolescents did decrease the success of CPAP use. As children are growing up, becoming teenagers, it's not cool to have to wear a CPAP mask at night to sleep, so this is another factor to consider. If a decision is made to proceed with CPAP, children can undergo CPAP desensitization with a pediatric sleep medicine specialist and get them accustomed to wearing a mask. They tend to send the child home with a mask and have the parents work them up a few minutes at a time every day up until they can wear the mask successfully without any air blowing through for 30 minutes. And then, of course, education and counseling for both the parent and child, for them understanding how important treatment of their sleep apnea is a big part of the treatment process. Oral appliances, there is limited data on this. Again, you may come back to adherence, and if a child will wear something in their mouth. There are more studies coming from our dental colleagues in regards to these options. Rapid maxillary expansion is also promising in these patients, especially the ones where you've identified high arched palate, dental crowding, malocclusion, whether this is genetic or the patient has been a mouth breather causing some of these palatal changes. They can benefit from the maxillary expansion surgery. Sorry, not surgery, the rapid maxillary expansion procedure. So what things can we do to better evaluate the airway for sites of obstruction post-tonsillectomy and adenoidectomy and we can't necessarily see in our office? Most of you are probably familiar with the drug-induced sleep endoscopy, whether you're a pediatric otolaryngologist or a general otolaryngologist performing these on your adult sleep apnea patients. An increasing number of studies have been published on the topic in pediatrics, showing that it's a very effective tool in identifying sites of obstruction. The two things I think are most important for a successful sleep endoscopy is patience, waiting for the patient to be in the right plane of anesthesia and breathing to get a good examination, and also really good communication with your anesthesiologist. You want to work with an anesthesiologist who is comfortable with an obstructing patient and a desaturating patient, as well as has experience in finding that right plane of anesthesia for these patients. Total IV anesthesia is the way to go. Some places will use dexmedetomidine and ketamine. Dexmedetomidine has been shown in studies to mimic non-REM sleep the best. Propofol is also, although more commonly used in adults, can be used in children with a good anesthesiologist. You want to avoid any topical medication in the nose, but suctioning gently prior to starting the procedure is appropriate, especially to counterbalance the secretions that will come up during induction of anesthesia. Where you stand is based on your comfort of observing the anatomy. If you stand on the side of the patient facing them, this is of course more natural for the otolaryngologist since that's what we do all day long. However, some, like myself, because it's how I was trained, stand at the head of the bed, so your image is quote unquote upside down. You want to observe every side of obstruction that's possible from the nasal passageway down to the larynx. You can also go further and perform a bronchoscopy at the same time, whether you're able to pass the scope through the vocal cords with your flex scope, or a rigid can be performed after the evaluation of the larynx has been completed, because you don't want to send the patient into spasm while you're doing the procedure. In the nasopharynx, you want to look out for adenoid regrowth, which can occur up to 15% of patients. If you stop at the choana, with and without a little jaw thrust, you can see the effect of the tongue base on the velum. Same at the level of the pharynx and the larynx. When you're looking at laryngomalacia, is it primary or is it secondary due to the effects of the tongue base? Is there tongue base collapse, or is it lingual tonsillar hypertrophy, or both? You've probably all seen these images several times when reading about sleep endoscopy. You also when attending lectures on the topic. I just think it gives a very nice breakdown of what to look for and what you may see. And this is one way of scoring what you might see in regards to no obstruction versus the different levels of obstruction. But there are several different scoring methods out there, and there really isn't a great consensus on which one to use. Another option, if available at your facility, is Cine MRI. Now, unfortunately, I do not have this option at the moment where I am, but a dynamic MRI has some great advantages. It's high resolution of the airway, and you can see both dynamic and static structures. Now, just like the sleep endoscopy, they do have to be sedated with spontaneous ventilation. So again, a good anesthesiologist who's able to manage this type of patient while they're in the scanner is very important. With the MRI, one of the great advantages is that you can see multiple levels at the same time, and it may give you a better idea as to how the structures are impacting each other. What is the tongue movement impact on the palate? Lymphoid tissue is also bright on MRI, so it can help you distinguish between lingual tonsil versus tongue-based collapse a little bit better. Comparing this to drug-induced sleep endoscopy, you do have the advantage of the 3D view with the drug-induced sleep endoscopy of the airway, and also being able to do concurrent surgery at the same time. This will limit the number of times your patient has to be under anesthesia. For the majority of my patients, when I'm proceeding with the drug-induced sleep endoscopy, I do sit down with them and consent them for all the possible surgeries that I can perform from nose down to larynx. It is a long discussion and can leave your OR timing a little uncertain, but there are ways around that as well, such as scheduling these particular patients last in the day so it doesn't impact your lineup. Reasons I may not proceed with surgery after sleep endoscopy is, for some parents, it's too much to have that much of a conversation or to not know what will be happening at the time of surgery. And some of them may want an evaluation first and then a discussion about whether surgery is the right option to proceed. Sometimes you're doing surgery at the same time as another specialty and you're just taking advantage of their OR time, with the dentists, with the orthopedic surgeons, again, limiting the number of times a patient has an anesthesia event. So you may not proceed with actual sleep apnea surgery at the time and do something in the future. There are some institutions that will do an MRI and a drug-induced sleep endoscopy at the same time, where the drug-induced sleep endoscopy is done while the patient is in the MRI suite. So this is another option. So moving on to surgical side of things, there are a plethora of surgeries that can be performed on these patients. There are, if you go through this list, all the way from the nose, again, down to larynx and tracheostomy for your more severe patients where nothing else is an option. There are a lot of things that can be done with the tongue other than lingual tonsillectomy and tongue-based reduction, including tongue suspension sutures, hyoid suspension, but I won't really be getting into that here. Turbinate reduction can have a big impact on sleep disordered breathing. There aren't any studies that talk about isolated inferior turbinate reduction for obstructive sleep apnea, but in this study by Chang et al. In 2012, the addition of inferior turbinate reduction at the time of tonsillectomy and adenoidectomy had a greater impact in reduction of AHI. I do tend to add inferior turbinate reductions frequently during the time of my T&A, especially in older patients who have a strong nasal history of congestion and mouth breathing, but likely will have smaller adenoids given their age. Of course, the nasal exam has to support this where there isn't deviated nasal septum or signs of chronic sinus disease. Revision adenoidectomy, as I mentioned earlier, has a regrowth rate of 15%, but the rate of revision is quite low at only 1.3%. A systematic review of 3 studies with 47 patients showed a significant reduction in AHI with the addition of a revision adenoidectomy. Lingual tonsillectomy has been shown to be a very effective procedure. Coltai et al. Showed reduction in HI of 18.1 to 2.2. And Manicam et al. In a systematic review showed 57 to 88% success when the AHI went down to less than 5. Although Kang et al. Showed that the cure rate was only approximately 17%, when looking at an AHI of less than 1, so essentially a cure, when the AHI was at least brought down to less than 5, this number had a greater impact on patient at 51%. Supraglottoplasty has also been shown to be effective in reducing the AHI. More often when you see laryngomalacia during a sleep endoscopy, it'll be in the form of redundant adenoid tissue falling into the airway, and this can be fairly easily addressed. Whether it's congenital laryngomalacia you're treating in a baby or a sleep-specific laryngomalacia in an older child, the studies show that there is good reduction in AHI. Now I just wanted to show you a few sleep endoscopies, and just a reminder, I do these from the head of the bed, so the video will be quote-unquote upside down. So going back, nasal passageway, floor of the nose is at the top of the screen for you. This is a child with Down syndrome, and what you'll see as we move forward down the nasopharynx here. Unfortunately, we didn't do a good job sectioning out those secretions, but you can see a pretty significant hypertrophy of the lingual tonsils here, leading to secondary laryngomalacia, collapsing that larynx there. So this child, at the same time, we placed him in suspension and proceeded with a lingual tonsillectomy, and he did very well postoperatively. This is just a little jaw thrust that we did at the end. Here's another video. This one, this patient actually, interesting, the look of adenoid facies and high arch palate on exam. You can see these obstructing adenoids in the choana. This is a sleep endoscopy post T&A. Pre-T&A patient had an AHI of 16. Post T&A, which is the reason we're doing this DISE, his AHI actually went up to 19. Couldn't see it very well earlier, but he does have turbinate hypertrophy and a pretty significant tongue-based collapse here. Not really much in the way of lingual tonsil hypertrophy, significant secondary laryngomalacia from the collapse here of the tongue base. So at least, actually, at this time, we only proceeded with turbinate reduction and revision adenoidectomy, and his AHI went down to 10. So, this is a child we may have to, consider rapid maxillary expansion, CPAP, moving forward. This is a patient who you can see here, pretty significant laryngomalacia with the poorly supported epiglottis. And you can see some lingual tonsils on the sides here coming out. This patient underwent an epiglottopexy and a lingual tonsillectomy at the same time, and went from an AHI of 22 to 3. This patient had cerebral palsy and has cardiac issues, so needed something done for the sleep apnea, but mom was almost positive. Mom pretty much said that she's not going to wear a CPAP mask. And this video I wanted to show you, this does mainly because I wanted to show one video that with the difference of primary and secondary laryngomalacia. This video does have, this is pre-tonsillectomy and adenoidectomy, so you can see adenoids here. And then as we move further down, you'll actually see quite large tonsils in this patient. Interestingly, on a clinical examination, this patient had what I thought were fairly small tonsils, but during the sleep endoscopy here, now you can see how obstructive these tonsils are. As the video continues, you'll see more of the tonsil pushing on the epiglottis, causing it to fold inwards and contributing to secondary laryngomalacia. But here is, again, a very poorly supported epiglottis on its own right. Now, the video is important, I think, because this child underwent a tonsillectomy and adenoidectomy with the thought that if there was still any residual sleep apnea or sleep stridor, that we would have to come back to do an epiglottopexy or see what else can be done to address the larynx. But with the decreased resistance of taking out the tonsils and adenoids, this patient actually did very well postoperatively and had resolution of their sleep apnea. So lastly, I just want to talk a little bit about children with Down syndrome. They have a very high incidence of obstructive sleep apnea. Earlier studies were close to 30 to 60%, but newer studies show that this range is likely much higher, trending towards almost 100% when it comes to the adult Down syndrome patient. With their mid-face hypoplasia, their glossoptosis, low muscle tone, and obesity, they are just more likely to have sleep apnea and more severe disease, and due to this have a higher incidence of residual obstructive sleep apnea, almost 50 to 75%. Most parents definitely underestimate their severity. Oftentimes they think that their child just doesn't sleep normal and it's just a part of being a Down syndrome child and this is the way they breathe. So the American Academy of Pediatrics recommends that any child with Down syndrome should have a sleep study by the age of 4. And our academy recommends every child with Down syndrome should have a sleep study. Special considerations on their sleep studies include hypoventilation, prolonged hypercarbia, which can be seen, and this can cause worsening issues of their underlying cardiac disease. Studies are small and sample sizes are small, but these children also spend reduced time in REM sleep, and this can cause more sleep fragmentation and, again, more issues, not only sleep apnea related, but just sleep stage related. So this leads me to talk a little bit about INSPIRE, or hypoglossal nerve stimulation in children with Down syndrome and obstructive sleep apnea. This is a prelim study. These results just came out last year, showing that an age range of 13 to 17-year-old Down syndrome children, non-obese, which is important, there was a median reduction of AHI of 85%. So these are very promising results. And right now, these treatments are only FDA approved for children 18 and older. 18 and older. And so hopefully with more studies in the future, we'll have more that we can offer our Down syndrome patients. So in summary, approximately 30% of patients with residual obstructive sleep apnea after tonsillectomy and adenoidectomy, and this incidence is higher in children with craniofacial anomalies or syndromic children, such as our patients with Down syndrome. Drug-induced sleep endoscopy and Cine MRI give good quality information to direct surgical management and can be used individually or together to augment decision making. Tongue, base, and laryngeal surgeries have very good outcomes for overall reduction in apnea-hypopnea index, but also don't forget the nasal surgeries, turbinate reductions, adenoidectomies. These things can also give significant improvement in AHI and quality of life. Hypoglossal nerve stimulation shows early reassuring results. And finally, never forget the importance of quality of life and what is being observed at home. Thank you very much.